Next question coming up. Let's put 2 minutes on the clock. And of course, this is coming into case 3, our final case for tonight. Question 1, your time starts now. All right, so great to see some answers coming through there. And the more astute of you may have noticed that halfway through the case she changed her name. Bugger. That's an editing mistake on my behalf, and I'll be fixing it up for later. I try and build cases and then go back and tweak things to make sure I'm actually trying to make it as diverse and lifelike as possible. So, whoops, missed one. Sorry. Now, I did go through, and I also changed the number of differential diagnoses. I wanted to try and focus it down a little bit. I do apologise. So, a couple of mistakes tonight. Sorry, guys. Let's focus on 3, although there are many more than 3. And as correctly identified, the most likely thing here is going to be vestibular neuritis. We've got that preceding viral illness and that constant dizziness and imbalance. So that almost classic for it, really. Of course, the other big thing that we really don't want to miss here would be cerebrovascular incident or stroke, or you could say TIA, but the fact that it's persisting would probably make me go back to the stroke kind of territory. We have Meniere's disease and vestibular migraine. So 100% correct on vestibular neuritis, and I'll point out here as well, actually just opportunistically and not to poke fun at all, but there's obviously a typo there. Don't sweat it. The college has said if there's spelling mistakes or typos or whatever, that's fine. As long as they know what you're trying to say, they don't actually care about the specific spelling, which for people like me is an absolute godsend. Now, you've fallen for my trap, my devious trap. I specifically didn't want this to include BPPV, or benign paroxysmal positional vertigo. Again, just catching you out just to try and avoid abbreviations as much as possible, because this is a constant dizziness, which pretty much instantly rules out BPPV. True BPPV is short episodic sessions of dizziness on movement, so triggered by an activity with very short bursts. It doesn't tend to actually last for long periods of time. Okay, so moving on, again, if you want to go through a really great place for differential diagnosis of vertigo, ETG actually has a really nice table and summary that I would strongly encourage you to read. There's also a couple of articles in Australian Family Physician as well that cover dizziness and vertigo, which you really have to read. This is something that is, again, not uncommon to be exam questions, but is also just one of those things that you're going to see time and time again. and is something that I think a lot of us probably could do better at and manage better if we know more exactly how to be targeting our therapies appropriately. Now, what is happening here? And we have IT troubles. When it rains, it pours, guys. Very sorry. Let's try that again. Let's bring that back up. Here we go. Perfect. It's like it never happened. You never saw anything. Let's get to the next question. 2 minutes on the clock, and your time starts now. All right, time is up. And for those who aren't familiar with the HINTS exam or haven't had to deal with this before, this exam will save you time and time again to help differentiate between central and peripheral causes of vertigo and dizziness, particularly for these cases. So we've ruled out stroke is probably one of the most important things here, and we think vestibular neuritis is the most likely diagnosis based on the symptoms that we have at hand, and so the HINTS exam essentially confirms that and excludes other central causes. That could be things like tumour or mass or change in pressure. So head impulse is moving the head to the sides very quickly, and you should see, while they're trying to look at your nose, I should mention, in particular you're looking for saccade to the side away from the lesion. If you're seeing saccades to the side towards the lesion, you're looking at some trouble, or if you're not seeing anything at all, warning signs should go up. If we have there's no signs at all, hints towards central, so that's bad. You want to be investigating further. For nystagmus, that's the horizontal movements of the eye. As they look to each side, you should see that kind of beating sign away from the side of the lesion. And if you're seeing that in both directions, again, that's your sign that there's something bad going on here. You need to expand to further investigations. Now, of course, there can be a rotational element to the torsion, particularly in the case of vestibular neuritis. That can be non-central. But if you're seeing vertical nystagmus beating vertically, you need to be considering central causes, and again, that's usually head to ED. Now, test of skew involves covering up eyes, and you'll notice as you uncover eyes, the eyes will have dropped down and then will jump back up once the eyes are uncovered. And again, there shouldn't be any skew. If you're seeing that lag and then catch up, that raise again once the cover is removed, that's hinting towards a central cause. This is something that I think, again, even just for day-to-day clinical practice, is one of those you really have to know kind of things. And again, will save your bum time and time again when you're thinking, oh boy, is this patient really, really sick? Or do they just need some therapy and rest and time and go home? Again, if you want more information on here, there is a little bit of information on ETG, but a quick Google search, you're going to find a heap of resources. And again, there's an AFP article that I would strongly recommend you read. And the Life in the Fast Lane website, if you're familiar at all with that, for emergency resources and critical care resources, have a really nice summary and a couple of videos as well that are definitely worth watching. This is one of those things, once you see it a couple of times with positive and negative examples, a lot of it makes a lot more sense. So again, strongly recommend you check those out. All right, moving on then to the third and final question for tonight. Thanks for sticking around this long. You probably all have better things to do at 9:20 on a Wednesday night, but love to spend it with you. Let's put 2 minutes on the clock, and your time starts now. All right, time is up, and we come to the final question. We knew there had to be something on pharmacology that's not just side effects at some point, so here we are. So again, stolen blatantly from ETG, prochlorperazine orally is first line recommended, but so is promethazine orally. And so I think you'd be pretty reasonable to prescribe either of those things. And I think you would likely see them put down as grouped as well, given they're both first line. It'd be a one or the other. I don't necessarily think you would get marks for both. The other thing that they would probably want to see there would be prednisolone orally, which has been shown to decrease the duration and severity of symptoms in some. So the evidence isn't fantastic, if I'm honest, and anyone that's had a patient with vestibular neuritis can profess it's an absolutely horrible condition, but patients will be desperate to take anything basically to try and make their symptoms better. And there is a little bit of evidence behind prednisolone, and so it is still recommended to be given. Now, of course, for the nausea, you can also use things like ondansetron orally, but the effectiveness of things like prochlorperazine and promethazine are going to be that much higher that you would likely get more marks for putting those things and knowing those things rather than using just your more standard, we'll say, antiemetics such as ondansetron. All right. Now, probably another thing I wanted to point out here is if you do go to ETG, one of the other things you'll see for nausea without vomiting is diazepam. And you will note it is not on this list here, and intentionally, because I think there is that bit of a push to not just follow guidelines blindly, and if we can get away without using benzodiazepines, there definitely is a lot of evidence to say use everything else first, and only then I think would you be justified in trying other things there as well. And so if you've only got 2 things here, I think all of these other things would be much better therapeutic options rather than benzodiazepines.